Good morning, everyone. And it's wonderful to be here in this DMDNB session. So this is going to be purely a learning session, and it will be learning for all of us together. We wish our DMDNB students to know more about ECGs, devices, EP, and we are going to keep it simple. At the outset, I welcome you all, and I request Dr. Ajay Naik sir and Dr. Yash Lokhandwala sir to give the opening remarks.
Thank you, Dr. Niti, and thank you, Dr. Deep, for this fantastic session that you've been conducting. Yesterday was International Women's Day, and the ladies have been in forefront of EP for a long time in India. This is nothing special for them, but we wanted to make sure that we have a good program, showcase the Indian talent, and have this entire session run by the ladies themselves. So Dr. Niti is the boss today. She's going to run the team, and we have a great match coming up later in the day. So Dr. Niti, please take over, and Dr. Yash, once he joins, he can put in a couple of words. I would like to thank Dr. Yash at this point because his Sion Hospital group was supposed to present today, but I requested him to just move it to the next month. So we could do this ladies program with coinciding with the International Women's Day. So looking forward. Thank you, Dr. Niti. Thank you, Dr. Deep.
Thank you, sir, for those words of inspiration. And I also thank Dr. Yash Lokhandwala sir for giving us this opportunity. So let us start the program so that we are just on time. The most important thing is to be on time. Is Dr. Deepti here? Can Dr. Deepti hear us? Okay. Dr. Amira?
Yes, ma'am.
Yeah, Dr. Amira, I request you to start the session. Dr. Deepti is having some problem in the login. She's been logging in and we are not able to see her or hear her. We'll start with you. Meanwhile, I help Dr. Deepti to log into this program. Thank you.
Sure, ma'am. Ma'am, are my slides visible?
Yes, they are.
All right. So, good morning, one and all. Our topic for today is ECGs, which got me thinking, and I will be mostly focusing on bradycardia. So I thought we'll describe it in form of scenarios. So I have basically 5 scenarios, but if I'm exceeding time limit, I will stop before. So in the first scenario, we have a 50-year-old male with fatigue and 3 pre-syncopal episodes since the last 2 months. And all his pre-syncopal episodes were post-exertion. So this is his ECG. So what do we see in this ECG? We have a PQRS followed by a P wave which is not conducted, and that continues in the entire rhythm strip. So what is this? So definitely it is a 2:1 conduction. So is it Mobitz type 1 or type 2 second degree AV block? So looking at this ECG, in a fixed 2:1 conduction block, it is not possible to identify whether it is Mobitz type 1 or type 2. When we see a fixed 2:1 AV conduction, instead of this, what we have to focus on is to identify whether it is a nodal block or an infranodal block. So what in the ECG helps us to find out whether it is a nodal or infranodal AV block? First is the QRS duration. So if you have a narrow QRS complex, it is most likely going to be a nodal AV block. However, if we have a wide QRS AV block, wide QRS complex, it is likely to be an infranodal AV block. But this rule doesn't imply in all the cases, because we could have a narrow QRS complex with a Hessian block, which is infranodal. We could have a nodal block with wide QRS complex in the case of bundle branch block, and we'll see examples coming up. So this criteria is not very reliable. So which is the next criteria which is reliable? The second criteria is a bit more reliable. We see the PR interval. If we have very long PR intervals, that is more than 300 milliseconds, this would go more in favor of a nodal block. Whereas if the PR interval is short, that is shorter than 160 milliseconds, it could be an intrahessian or an infrahessian pathology. Whereas somewhere in the ECG or in a Holter, we are able to pick up a Wenke-Back phenomenon. This would be a AV nodal block. Now, there could be some maneuvers which we could do to find out whether it is a nodal block or an infranodal block. Anything which would exaggerate AV nodal conduction, like atropine or exertion, would improve a AV nodal. Would improve a AV block if it is of nodal origin. However, if it is of infranodal origin, it would worsen it. On the contrary, if we do a carotid sinus maneuver, since we are giving a vagal impulse or vagal dominance during this time, it would worsen the AV block if it is of nodal origin. However, an infranodal block would conduct better because we are going to also slow the sinus rate. So a disease infranodal system would conduct it better. So it would look as if the AV block is improved. So let's see some ECGs. Now in this ECG, we see a 2:1 conduction. However, the QRS complex is wide. But to note here, the conducted PR interval is more than 300 milliseconds. So like I said previously, the second criteria is more important. So this is more than 300 milliseconds. So this is likely to be a nodal AV block. Now during maneuvers, this is a 2:1 AV block. We are giving atropine. What is happening here? We are getting a Wenke-Back phenomenon, which means it is an improvement in 2:1 AV block. If you see there, for every fourth beat, we have a block. That means 3 are conducting and the fourth beat is not conducting, which is an improvement. This is a Wenke-Back phenomenon with 4:3 AV conduction. This is a Mobitz type 1 AV block, which means this AV block would be a nodal AV block. Next, this on the ECG-A is a 2:1 AV block ECG. However, when we are doing a carotid sinus massage, it is changing over to 1:1 response. And if you notice, the QRS is widening there. It could be rate-related aberrancy, but the 2:1 block is changing to 1:1 block on carotid sinus massage. So this is a infranodal pathology. Well, there could be a scenario where with all these maneuvers, nothing happens. 2:1 remains fixed. So what it could be due to? It could be either we are not doing the maneuver properly or it is an intrahisian pathology. Intrahisian pathology. So what did we learn with this? Fixed 2:1 AV block cannot be categorized as Mobitz type 1 or type 2. Fixed 2:1 AV nodal block could be nodal or infranodal, and we have learned how to differentiate it on with the ECG clues and with maneuvers. Moving on to scenario 2. Here we have a 13-year-old male child who has been operated for inlet VSD closure, and he has been referred for fatigue and bradycardia. So this is the ECG. Now we know it is an inlet VSD closure. We have a bifascicular block pattern, RBVP in the precordial leads, and we have a left anterior hemiblock which is there. So bifascicular block is a relatively common finding post-operative in the VSD closure patient. But what is happening to the rhythm? 1:1 conduction is suddenly becoming 2:1 conduction. Right? So what is this now? Is it a 2:1 AV block? Let's analyze this. Whenever we are dealing with 2:1 AV block, we have to see that the P2P intervals are relatively constant, whether it is a Wenke-Back phenomenon, which is on the right side of the ECG, or a fixed 2:1 AV block, P2P intervals are relatively fixed. But what is happening in this ECG? Here, this is one P wave, this is another P wave. And we see that in between whichever QRS is coming, that P2P interval is much shorter than the subsequent P2P interval. So when does this happen? Irregular PP intervals at 2:1 conduction. That is what we are looking at. So describing this ECG now, here also we are seeing 2:1 conduction, but the gap between or the P2P interval with the QRS interval with the QRS is shorter compared to P2P interval without the QRS, and that continues throughout the ECG. So this is a phenomenon called ventricular phasic sinus arrhythmia, and this arises because whenever there is a systole, it improves the blood circulation to the sinonodal artery, And that is why the P wave comes earlier. This is called a positive chronotropic effect following a QRS or following a systole. Right? So this is ventricular phasic sinus arrhythmia. But note here, the P waves are of similar morphology. What is happening to our reference ECG? The P wave is definitely early, but the morphology is also different. If you see V1, this is negative, this is fully positive, and it is coming early. So this is a blocked atrial bigeminy. This is a very common phenomenon in pediatrics, and this is a neonatal ECG. Another ECG which is also showing blocked atrial ectopics. This is not a bigeminy pattern. Sometimes it is trigeminy, but a definite pattern is not there. But definitely we could know that it is different from the PVF morphology. So this is a common entity in pediatrics. So what did we learn from this scenario? 2:1 AV block with fixed PP intervals. Whenever it is a 2:1 AV block, we will have relatively fixed PP interval. However, when 2:1 conduction is present with bradycardia and irregular PP intervals, we could have ventricular phasic sinus arrhythmia and blocked atrial bigeminy, like we learned in this case. Moving on to scenario 3. We have a 6-year-old female child, known case of SLE, and she is on treatment for SLE. This is her ECG. So looking at the 6-year-old ECG with normal P waves, normal sinus P wave, and RR irregularities, the first thing we would think of is sinus arrhythmia. That's what the algorithm is also saying. But is this really sinus arrhythmia? So let's go to the definition of sinus arrhythmia. So how do we define sinus arrhythmia? So we should have P wave morphology, which is resembling normal sinus rhythm, which is there in this. The shortest P2P and the longest P2P should vary by more than 120 milliseconds, or it should vary by more than 10%, the shortest and the longest, either more than 120 or the 10%, which is again satisfied here. And the PR interval should be constant. That is also satisfied here. So technically, this is a sinus arrhythmia ECG. But is there something very peculiar happening here? Yes, there is something peculiar happening here. The P2P intervals are serially shortening, and followed by that, there is a pause happening. So, what is this entity? So, this is something called sinus SA nodal exit block. And this is a condition where the impulse generated in the sinus node, but it is failed to conduct the atria. So, there are two basic types of SA nodal exit block which are seen on the ECG. We are not going to focus on type 1 ECG because it cannot be seen on the ECG. We are not going to focus on type 3 SA nodal exit block because it is almost similar to sinus arrest. But what is noticed on second degree a sinus exit block on the ECG is type 1 pattern or type 2 pattern. In type 1 pattern, the PP intervals gradually decrease, followed by a pause, and the pause duration is less than 2 times the shortest PP interval. Whereas in type 2, the PP interval is constant, and when there is a pause, it will be a multiple of that PP duration. So let's go to ECG example. In our reference ECG, which we had for the 6-year-old patient, what we are seeing here is the pause which is there after the serial sequential PP wave decrement. What we are getting here is a pause which is less than 2 times the shortest PP interval. So this is type 1 second degree SA nodal exit block. However, when we have an ECG which is showing a pause which is 2 times or 3 times the fixed PP interval, this would be in favor of a type 2 second degree SA nodal exit block. So what did we learn here? Irregular RR interval with a normal P wave morphology with 1:1 AV conduction is mostly sinus arrhythmia. However, when we see patterned PP intervals with pauses, it could be sinuatrial exit block and it should be looked for in the ECG. Scenario 4. We have a 39-year-old police officer with recurrent symptoms. Yes, ma'am?
It's about time now.
Sure, ma'am. We'll stop at that.
Yeah, thank you so much. It was a wonderful presentation, really. I request Dr. Deepti to carry on with the session now. Dr. Deepti?
And good morning, everyone. I'll just share my slides.
Yes, please. Dr. Molly, can you hear us?
Are my slides visible, ma'am?
Just hold on.
No, not yet.
Not yet.
Okay.
You see, Dr. Molly is online. I can see her. She's muted. That's all.
Please, Dr. Molly, ma'am, please say hello if you can hear us.
Yep, I can hear you. Hello.
Yeah, wonderful. That's great. Okay, ma'am. So, Dr. Deepti, we are still not able to see your slides.
We're able to see you though, Dr. Deep.
Good morning, ma'am.
Yeah.
It says I'll have to leave the webinar and then rejoin.
Oh, God.
Wait a second.
Share.
Yeah, doesn't matter, Neeti. While she does that, maybe you can have the moderators speak about ECG,
Yes.
discuss a bit.
Perfect. So, for the session, I welcome the moderators, Dr. Molly Shah, Dr. Aparna Jaswal, and Dr. Sharda Madam.
Yeah, good morning, everybody. Dr. Mole, especially good morning. Yeah, Aparna is going to be late in join.
Yeah, ma'am, we can see you. So,
Yeah, hi, Aparna.
some comments from the moderators, please.
Yeah, beautiful cases. The first case I just wanted to add, Dr. Amira's cases are really practical and we see them quite often. But I had similar observations that when you start exercising these type 2 blocks, the first thing that you start seeing is that the QRS starts widening. Even before block worsens, what you'll notice on even a modified bruise, even in the stage 1 first minute, what happens is the QRS definitely starts widening. You'll see more and more blocks before it worsens to our really slow rates. Yeah. Otherwise, very comprehensive review, Amira. Thanks. I wish we had time for the fourth case, but well done. Yeah.
Thank you, ma'am.
Are my slides visible now, ma'am?
They are visible.
Yeah, they are.
Can we just, Dr. Deepti, give me 2 minutes?
Sure.
I want some comments from Dr. Molly Shah ma'am and Dr. Aparna Jaswal.
Yeah, I mean, actually, I have nothing to add. I think it was a very comprehensive explanation. Well done. I think you were very clear in describing both cases. I have no questions or comments. I think it was very clear in the way you described your cases.
Right.
Ditto. I think let's move to the next. Thanks.
Perfect. Dr. Deepti, we are ready to listen to you.
Okay, ma'am. Good morning, everyone. Thank you to the organizers for the kind invitation. I'll be discussing on the approach to broad QRS tachycardias in the next 10 minutes. I'll start with an example. This is a 12-lead ECG that shows a wide complex tachycardia. There is no obvious AV dissociation. In fact, if you look at V1, you can see some candidate P waves suggesting 1:1 VA association. There are no fusion or capture beats to classify it as a ventricular tachycardia. So how do we go from here? Let's see what all can cause a wide complex tachycardia. The first thing that comes to mind is ventricular tachycardia. Most of the ventricular tachycardias are myocardial in origin, but a small subset utilize the conduction system for its initiation or propagation. The second closest differential is SVT with aberration. It could be either functional due to rate-related block during the tachycardia, or it could be pre-existing, in which case a baseline ECG will be helpful. The third differential is a pre-excited SVT that uses an accessory pathway as the antegrade limb of the circuit. This pathway could be an obligatory component of the circuit, as happens in antidromic AVRT, or it could be a bystander in atrial tachycardia or AVNRT. Apart from these three obvious causes, always remember that paced rhythms can give rise to the wide complex tachycardia, or it might not be a tachycardia at all, but an artifact. With this background, let's see what all information we have from our ECG so far. So as I discussed, there is no AV dissociation, no capture or fusion beats, and at this stage, we don't have a baseline ECG available for comparison. So the key discriminator here will be QRS morphology. What is the QRS morphology here? So lead V1 shows a right bundle branch block type of pattern. The question is it a typical right bundle branch block, which would suggest that it is happening through the conduction system and therefore is either an aberration or a VT using the conduction system, or is it an atypical bundle branch block? A number of algorithms have been published just to address this question, how to classify a particular QRS morphology as typical or atypical. A number of morphological criteria are also described. But the question is, do we really need to memorize all these empirical observations, or can these criteria be logically understood? I'll show you this diagram which shows the placement of the precordial leads on the chest. These precordial leads actually record unipolar signals from the heart muscle. Anything traveling towards these will record a positive deflection, and anything going away from these will record a negative deflection. See how the lateral leads, especially V5, V6, directly overlie the LV myocardium. Any impulse which is using the conduction system to propagate will reach these two leads with a very brisk initial intrinsicoid deflection, as we can see in the ECG. It will take less than 80 milliseconds to reach the peak. On the other hand, any impulse which is propagating through the myocardium, as happens in a ventricular tachycardia or an antidromic AVRT, this impulse will drag its feet. It won't be very brisk intrinsicoid deflection. It will reach the peak in more than 100 milliseconds. So let's see if we can apply this to our ECG. So our ECG's lead 1 shows a right bundle branch block pattern, which is not exactly the garden variety RBBB. But what is happening in the lateral leads? Look at that. The initial activation is so brisk that it's almost over in less than 40 milliseconds. No impulse that is traveling through the myocardium can lead to such a sharp deflection. So that practically rules out myocardial ventricular tachycardia. Pre-excited tachy also becomes very unlikely, as antegrade conduction over an accessory pathway is more or similar to what happens during a ventricular tachycardia. So what are the options that we are left with? Obviously, it's not a paced rhythm or artifactual tachycardia. It's not a myocardial VT, and it's not a pre-excited SVT. So we are left with these two options of SVT with aberration or VT which uses the conduction system, the former being the first probability. So this ECG belonged to a young boy with Epstein anomaly, whose baseline ECG showed manifest pre-excitation, and EP study showed the mechanism to be orthodromic AVRT. The atypical right bundle branch block was because of the underlying Epstein anomaly. Let's have a look at the second ECG. Again, a wide complex tachycardia, no obvious AV dissociation, no fusion or capture beats. So we'll need to resort to morphology again. I apologize for the poor quality. But as you can see, so what is the morphology? Lead V1 shows a left bundle branch block like pattern. And the lateral leads V5 and V6 again show a very sharp intrinsicoid deflection, less than 40 milliseconds here. Again, that practically rules out a myocardial ventricular tachycardia. We really need not apply all those morphological criteria to arrive at this conclusion. A pre-excited SVT mediated via a typical bypass tract is also ruled out because, as I explained earlier, a typical accessory pathway will depolarize the myocardium in exactly the same fashion as a ventricular impulse. However, this is a special entity because this has something that we call typical left bundle branch block with a superior axis. We have some variant accessory pathways that insert directly into the right bundle. This is the atriofascicular pathway and this is the nodofascicular pathway. So when these pathways participate in a pre-excited tachycardia, they can actually give rise to a very typical left bundle branch block, because after all, the impulse is traveling in the normal conduction system with a superior axis. So in this case, our differential diagnosis will be SVT with aberration, because statistically it is more common, a pre-excited SVT utilizing an atriofascicular or rarely a nodofascicular connection, and a ventricular tachycardia involving the conduction system like a bundle branch reentrant VT. I think I have time for one more. So this is the third example of a wide complex tachycardia. Again, no VA dissociation, no capture beats, no fusion beats. Again, we'll need to look at the morphology. So what does this one show? V1 has right bundle branch block. Is it typical? I'm not very sure. But look at V5, V6. The initial activation is over in less than 40 milliseconds. So again, myocardial VT is unlikely, pre-excited SVT is unlikely, and we are left with these two options. This turned out to be a fascicular VT with the typical right bundle branch block and a left axis deviation. This is another wide complex tachycardia, which has a 1:1 VA association clearly seen here. No fusion beats, no capture beats. So even to an untrained eye, you can see that the right bundle branch block here in pattern in V1 is completely screwy. It's not at all typical. And this is corroborated by the initial activation in the lateral leads, which is so sluggish, so tardy, that it takes about 120 milliseconds to reach the peak of QRS. So straight away, you can rule out any rhythm that is using the conduction system here, unless, of course, the baseline conduction system of the heart patient is diseased. So obviously not paste or artifact, not SVT with aberrancy, not a VT which is using the conduction system. It has to be VT or a pre-excited SVT. This turned out to be an antidromic AVRT using a left lateral pathway. I'll just finish off with this one. So this example shows why you should consider all 5 possibilities when you're beginning to analyze your rhythms. This was recorded on telemetry one day after an anterior wall MI, and the resident got very concerned about this wide QRS rhythm and started amiodarone. The next day EP was called, but on evaluation, if you really look closely at the tracing and apply your calipers, you will see that regular QRS complexes are happening as in the sinus rhythm. So this actually was an artifact due to altered filter settings on telemetry. So always keep all your 5 options at the back of your mind when starting to analyze a rhythm. I'll stop here, Dr. Neeti.
Perfect, Dr. Deepti. That was a really wonderful presentation. You've
summarized the last few ones. So just remember all these 5 causes and the pattern of activation. That will help you in the majority of the cases. Thank you, Dr. Neeti.
Perfect, Dr. Deepti. I think that was a wonderful presentation, and you summarized various scenarios very nicely. Moderators, please.
Yeah, I think I'd like to congratulate her. But I think there's one point which I do want to bring in, that whenever you're trying to distinguish a wide complex tachycardia, the last ECG which she showed was very nice. The traditional teaching has been, when you see a positive or a negative concordance, V1 to V6, you begin to think it is a VT. But remember, if you see, like she showed, a positive concordance in V1 to V6, you should also keep in your mind, am I dealing with an accessory pathway? A negative concordance, nearly all the time you're dealing with a VT. But a positive concordance is, you should consider you could be dealing with an accessory pathway. The second thing, Dr. Deepti, we would have appreciated if you showed the first ECG which you showed of Epstein's supraventricular tachycardia, the sinus rhythm ECG. I was trying to be, but the ECG was small. I don't know. I was trying to look for a right bundle in a sinus rhythm. The reason is, I somehow in that little time I could not see it.
Oh, do you want to share it again, or?
Yeah, you can just show that ECG, and then we'll request Dr. Molly to comment on that, because I think she's the right person to speak on Epstein's and a sinus rhythm ECG and the SVT.
So the sinus rhythm ECG actually showed manifest pre-excitation. It was not helpful in showing that right bundle branch block.
Yeah. So if you could put it full screen, I think I'd request Dr. Molly to come in here. This is what I wanted her to discuss.
Yeah, so thank you for that, Aparna. I think the point we would like to make here is that when you see an Epstein's ECG in sinus rhythm, by default, every Epstein has a right bundle branch block morphology at baseline. So the absence of a right bundle branch block morphology at baseline, even if you don't see the pre-excitation pattern, essentially means that there is pre-excitation. And the reason you don't see an obvious pre-excitation is often Epstein's patients have atriovesicular pathways, and because there is a diseased atrialized right ventricle, the accessory pathway and the slow conduction across the conduction system and through the atrialized myocardium cancel the effects of each other. So sometimes even when there is pre-excitation, you might get a very normal looking ECG. So always remember in an Epstein's, if you don't see right bundle branch block at baseline, that pretty much tells you that this is actually overt pre-excitation, even if you don't see the classic short PR interval in a delta wave. So in this case, I think the pre-excitation is very well seen, but there are cases of Epstein's where the PR interval is normal and you might just see a little bit of right ventricular conduction delay without any obvious delta wave. So just remember, if you don't see right bundle branch block in an Epstein's at baseline, that pretty much tells you that there is pre-excitation. So in this case, you see pre-excitation at baseline, and then during SVT, obviously this pathway seems to be conducting during SVT as an orthodromic reentrant tachycardia and not antidromic, and that's why you see right bundle branch block, which would be, so if you ablated this patient, the underlying ECG would show you a right bundle branch block. So this is not aberration per se. It's not rate-related aberration. The right bundle branch block in Epstein's is the morphology that the sinus rhythm conducts through.
Yeah, thanks, Molly. That's exactly what I was wanting, that you should bring that out. There is no rate-dependent aberrancy here. This tachycardia, the right bundle, is just because of the Epstein's.
Dr. Sharda?
Yeah, but your presentation was great. I think this is one of the clearest differential diagnoses of wide complex tachycardias that I have heard. So congratulations. I think you did an amazing job. And I really like the fact that instead of trainees memorizing these algorithms, you're actually focusing on the fundamentals and not just pattern recognition. So congratulations for that.
Thank you, Dr. Molly. Dr. Sharda ma'am, any comments?
Yeah, definitely. It's too many cases in a very short time that Dr. Deepti tried to give across. Each of them would require that much time, I think. Yeah, beautiful illustrations, but I think at least for my PG students, it's a bit still white PRS is, while as Dr. Molly says, it is simplified, but still, as you understand, even with initial depolarization being very fast, you still have to think of fasciculovitis when the morphology is typical. So there are always exceptions to the rule, but by and large, faster depolarization does mean an SVT with aberrancy, and a slower initial depolarization would you think of a myocardial beat-to-beat connection or myocardial spread, so which would mean a VT or an antidromic tachycardia. So, but yeah, it's really very difficult to simplify, but the case examples, if somebody can ponder over a little bit and go through, they're a great teaching examples. Thanks, Dr. Deepti.
So thank you. Thanks, Dr. Deepti. Wonderful session. And I think if there are no more comments, we can wind up the ECG session and we go on to the EP session now.
Yeah, just wanted to add that right bundle morphology in Epstein's is obviously just everybody knows, but just to reiterate for the PGs again that it's due to the atrialized part of the right ventricle adding a bit of delay to the right bundle depolarization. Yeah, thanks.
So we go on to the EP session now. I request the speakers, Dr. Deepti and Dr. Sukriti, to come in. And maybe we can start with Dr. Deepti now.
Okay, ma'am. I'll just share the presentation. I'll close the previous ones. I think it's...
Yeah, it's there now. We can see.
Can you see this one?
Yes,
This maneuvers one? Okay.
Yes.
Okay, thank you. Good morning again. I'll be presenting, I'll be discussing about one of the most commonly used, just give me a minute, ma'am. I'm not able to change my slides. Okay.
Yes.
Okay. So I'll be discussing about one of the most commonly performed maneuvers in the EP lab of scanning the diastole with PVCs during tachycardia. We'll try to understand this with the help of an example. So this is a tracing which shows a narrow QRS tachycardia interrupted by a PVC here. So how do we analyze this? It is always a good practice to analyze the tachycardia first rather than jumping onto the maneuver directly. So we have a narrow QRS tachycardia with a cycle length of 290 milliseconds, a septal VA interval of 80 milliseconds, a positive HV interval, which was the same as that seen during the sinus rhythm, and an atrial activation sequence with the earliest electrogram at CS910. So it could be anything, an orthodromic AVRT or an atypical AVNRT or an atrial tachycardia. Let's look at the PVC now. So this PVC was delivered from the right ventricular apex. The QRS morphology is different from that of the tachycardia QRS, but it's also different from what one would have expected from an RV apical pace beat. It should have been a little broader. The His deflection is seen just after the stem artifact, but what is to be noted is that the morphology as well as the timing are exactly similar to all the previous His bundle deflections as well as the later His bundle deflections. What does that tell us? It says that this His bundle has been activated anterogradely by the previous tachycardia beat. It has not been activated retrogradely by the PVC that was delivered. So this is what we call the classical His refractory PVC. Before moving on further with the trace, let's see how one can determine if a PVC is His refractory or not. The easiest indicator is evidence of fusion in the QRS complex morphology. Consider this diagram. This PVC is delivered when the His bundle is refractory. That means it has already been activated from above. So now the ventricular myocardium is going to be activated by two wavefronts. One from above downwards, the antigrade wavefront, and one from below upwards from the retrograde wavefront from the PVC itself. So the collision of these two wavefronts will lead to fusion, which is inevitable. So whenever you see QRS fusion on the ECG, that implies that a PVC has been delivered when His bundle was refractory. Other indicators of His refractory PVC include if the pacing stimulus occurs just after a discernible antigrade His potential, or if the paced QRS complex occurs no more than 35 to 55 milliseconds earlier than the anticipated timing of the antigrade His potential. What is an antigrade His potential? A His bundle deflection which has the same morphology and the same timing as the previous and the subsequent ones. If it is not His is not refractory when the PVC is delivered, it will be earlier and different in its morphology. I'll show an example on how to recognize if a PVC is His refractory or not. Same patient, same tachycardia. We start scanning the diastole with PVCs, with each subsequent PVC coming 10 milliseconds earlier. This is the first stimulus. No change in QRS morphology. It's exactly similar to the tachy-QRS. The next one, about 10 milliseconds earlier, still no change. Another one, even earlier, it is appearing just after the His deflection. I'm not sure if you can see, but the lead 2 actually shows us a slight slurring here, but not very crystal clear. Now this is the fourth PVC that is about further 10 milliseconds prematurity, and this appears just right where the next His bundle would have been expected. Look at the QRS here. There is definite fusion here. It is not similar to the tachycardia QRS. That initial R is lost, the height of the QRS has decreased. And it's definitely not like an RV apical paced beat also. It's narrower, it doesn't have that typical left bundle branch pattern that you would have expected with an RV apical paced beat. So this PVC is His refractory, and you can tell that even without looking at the intracardiac electrograms. So how did this His refractory PVC affect our tachycardia? The QRS is obviously early because the stimulus has arrived early here. But what has happened that the next atrial electrogram, which are visible in the CS channels, has also arrived early. In other words, atrial activation has been advanced by 40 milliseconds. How do we interpret this response? We'll go back to our diagram. This PVC has been delivered when the bundle is refractory. So there is no way that it can travel retrogradely via the normal AV nodal axis and affect the atrium at all. So the fact that it has been able to advance the atrium indicates that there was an alternative route available for it, which was the accessory pathway. So this response demonstrates the presence of an accessory pathway. This need not be necessarily an obligatory part of the circuit, because even in atrial tachycardia or AVNRT with a bystander AP, the atrium will be advanced. So this is how His refractory PVC affects the three different mechanisms of SVTs. While there will be advancement of the next atrial EGM during AVRT, there will be no effect in AVNRT or atrial tachycardia on the next atrial activation if there is no additional or bystander accessory pathway is present. This response is very specific for the presence of an accessory pathway, but does not prove participation of the pathway in the circuit. However, this is not very sensitive because the PVC needs to have a very good access to the ventricular end of the pathway to generate this response. For example, consider that while we are pacing from the RV apex, the pathway is located somewhere here in the left lateral annulus. In that case, this PVC has to travel a long route to engage the ventricular end of that pathway and might not advance the atrium at all. So this needs to be remembered. His refractory path PVC can give rise to two more responses, and we'll discuss that shortly before we end. So this is response 2. Again, a narrow QRS tachycardia, relatively long VA interval. These are the atrial EGMs and these are the ventricular EGMs. Positive HV interval, and a PVC has been delivered, which is pretty late coupled. You can appreciate the QRS fusion again, and that proves that this PVC was delivered when the His was refractory. How has it affected the tachycardia? It has terminated it. And what is the nature of termination? You can see all the QRS complexes, the ventricular EGMs, according to that. But while the P waves were clearly visible in the ECG to begin with, you can see these negative P waves in lead 2. There is no P after this QRS, and there's no atrial EGM after these ventricular electrograms. So this PVC, which was His refractory, has led to termination of the tachycardia without any conduction to the atrium. How do we interpret that? Again, this PVC cannot go back to the atrium via the AV nodal axis because His bundle is refractory already. So the only way it can affect the tachycardia if there is an alternative route. So the presence of accessory pathway is not in question. The fact that it has blocked in a critical component of the accessory pathway and has failed to generate any atrial electrogram or P wave proves that this pathway is an obligatory component of the circuit. So this response actually proves not only the presence of a pathway, but also its participation as well. I'll go on to the next response. So this is again a narrow QRS tachycardia, long VA tachycardia. These are the atrial electrograms. And this has an eccentric pattern. See how the right atrial electrogram and the CS electrograms are preceding the his bundle atrial electrogram. So we already know that there should be a pathway here. So what has the his PVC done here? The QRS is fused, so obviously it's his refractory. And what it has done here, that instead of advancing, it has delayed that next atrial EGM. The very fact that it has affected the atrial EGM proves the presence of the accessory pathway. Now, how do we explain that delay? The delay is because of the nature of the pathway itself, which is slow and decremental. So it takes some time for the PVC, which has appeared earlier, while the pathway retrograde refractoriness is not recovered, and takes some time to go into the atrium so that the next atrial EGM comes a little later. So this maneuver also proves the presence as well as participation of the accessory pathway. And then it also gives you information about the pathway characteristic, that it has a slow and decremental retrograde conduction. Very useful in long RP tachycardias where your normal entrainment indices might not clearly differentiate the mechanism. So to summarize,
Yeah.
I'll just do the summary, ma'am. So to summarize, we can have these 4 responses to a his refractory PVC. Advancement of atrial activation is very specific for the presence of AP, but the lack of advancement does not necessarily rule out the presence of a pathway. Termination without conduction to atrium proves presence as well as participation. Delay of atrial activation proves presence, participation, as well as the nature of the accessory pathway, that it's slow and decremental. And no effect does not really give us any much information, except for that it could still be an AVRT with poor access of the PVC to the accessory pathway. I'll conclude with that. Thank you.
Wonderful presentation, moderators. We can have the second EP session and then we can call in the moderators, please. Dr. Sukriti?
Yeah, morning, ma'am.
Yeah, hi. Please start with your presentation.
Yeah, a very good morning to all respected seniors. And ma'am, are my slides visible?
No, not yet.
Let me try.
So meanwhile, moderators can comment on Dr. Deepti's presentation. I think it was a wonderful representation of his refractory PVC.
I think,
Yeah, I think it was great too. Go ahead, Aparna.
I think it was wonderful, but there was just one comment that I wanted to tell for the sake of completion, that one must remember if his refractory PVC is more premature, you may be able to bring in the A early, even in an AVNRT. So as she very wonderfully depicted that his synchronous PVC has truly to be timed with the his. So that's a point which you must remember. If you aggressively bring it in too early, you may precede the A even in an AVNRT. But wonderful, congratulations.
Yeah, and
But yeah,
Ma'am, are my slides visible?
yes, they are.
So a very good morning to all respected seniors and my colleagues. I'll be presenting a case of right ventricle outflow tract PPC. I'm Dr. Sukriti Rana, EP Fellow from Fortis Scott's Heart Institute, New Delhi. So we had a 43-year-old male, an Iraqi gentleman who had no comorbidities, but he had presented to us with complaints of recurrent palpitations and dizziness for the past 2 years. His physical examination and biochemical profile was unremarkable. His ECG showed frequent VPCs with sinus rhythm. His coronary angiogram was normal. His 2D echo and cardiac MRI showed a structurally normal heart. His symptoms persisted despite medical therapy, and his 24-hour Holter monitoring showed a significant VPC burden of 40%. So this is his 12-lead ECG, which revealed frequent VPCs. Before we discuss this ECG any further, let us take a look at the relationship of outflow tracts. This is a longitudinal section of the heart which shows the right ventricle outflow tract being located anteriorly and to the left of the left ventricle outflow tract. The coronal section on the other side shows a closer look on the same. We can see the right ventricle outflow tract is situated anterior to the left ventricle outflow tract. But the semilunar valves are not isoplanar. The pulmonary valve is situated 1 to 2 centimeters superior to the aortic valve. So the right ventricle outflow tract in the lower part is in close proximity to the left ventricle outflow tract. However, in the upper part, it is in relation to the aortic valve and the aortic sinuses, the closest being the right coronary sinus. Now, there are various algorithms which help us to reach the potential anatomic site of origin of a VPC. The simplest being the morphology of R wave in lead V1. Now, if we look at the structures which are located beneath the lead V1 from anterior to posterior, they are anterior RVOT, posterior RVOT, the right coronary cusp. Now, this is a confluence of three structures: the left coronary cusp, the non-coronary cusp, the aortomitral continuity. The posteriormost being the posterior mitral annulus. Now, if a VPC arises from the anterior RVOT, it will have a wave of depolarization which moves away from the lead V1. So as a result, it will produce a LBB-like morphology in lead V1. However, if it arises from the posterior mitral annulus, it will move towards the lead V1 and produce a RBB-like morphology. But for the structures placed in between, from the posterior RVOT to the aortomitral continuity, there will be a gradual increase in the amplitude of R wave from anterior to the posteriorly placed structures. So a look at the R wave in lead V1 can sometimes give us a clue to the potential site of origin of VPC. As we already discussed, there are multiple algorithms. The another one is that proposed by Enrique et al., which gives us a stepwise approach for the analysis of the origin of VPC based on the ECG. Now, this is a very busy slide. We'll discuss it in context of the ECG of our patient. Before we do that, we must understand that for the localization of a VPC in a structurally normal heart, the heart is divided into 4 quadrants, 2 superior and 2 inferior. The first step to localize the origin of the VPC is to look for the morphology of QRS complex in inferior leads. If the QRS is positive in inferior leads, that means the vector is arising from the superior quadrant, either right or left, and going inferiorly. So the VPC in our case was coming from either the right or the left upper quadrant. The second step is to look for the morphology of QRS during VPC in lead 1. Lead 1 is a left-sided lead. So any vector which moves towards the lead 1 will have a positive QRS. That means the vector is coming from the right side and going towards the lead 1. As a result, we could narrow down our VPC to be originating from the right upper quadrant. The third step is to look for the morphology of QRS in lead AVL. Lead AVL is a superiorly placed lead. The structures which are superiorly placed in the right upper quadrant include posterior RVOT and RCC, as compared to the 2 other structures that are parahesian and the superior tricuspid valve. The 2 structures are relatively placed inferiorly. So if a VPC is originating from either posterior RVOT or right coronary cusp, it will have a deflection that goes away from the lead AVL and hence produce a negative QRS in the lead. The fourth and the last step will include looking for the lead which shows the transition. In our case, the transition was seen in lead V3. So our VPC we could narrow down our VPC to be originating from either posterior RVOT or RCC. In view of symptomatic status and poor response to medical therapy, we took our patient up for 3D mapping. Now the figure shows the 3D anatomic reconstruction of the RVOT of our patient. And we could see the origin of the VPC could be localized to the posterior RVOT, as could be seen from these EGMs. This is a unipolar EGM which shows a QS morphology at the nailed site, which is the posterior RVOT. The QS appearance of the EGMs means the VPC is originating from that side and spreading out all over the ventricle. The bipolar EGM also show the origin to be located to the posterior RVOT as it precedes the onset of QRS by about 30 milliseconds. Now, this is the template of the clinical VPC which you use to give symptoms to our patient. The propagation map again emphasizes the focal nature of our VPC. As we can see here, the VPC is originating from a particular point and spreading out in all the direction, ruling out and making it unlikely to be a re-entry arrhythmia, which has an early late phenomenon. Once the origin of VPC was localized to the posterior RVOT, we gave 3 lesions at the side, which lasted for about 40 seconds at a power of 30 watts. The VPCs disappeared during the first session itself. The procedure was successful and the patient was asymptomatic. So this is his ECG post-ablation. And as we can see, a person who had a 40% VPC burden shows a normal sinus rhythm without any VPCs. The patient is still in our follow-up. His repeat halters show no VPCs and he's off his medical therapy. So the understanding of morphology of VPC on the surface ECG not only helps us to decide the site of origin of the VPC, but it also helps us to choose the appropriate site of access for giving the lesions. So just emphasizing the same anatomic correlation of the right and the left ventricular outflow tract, we had taken a angiogram from the root of aorta. As we can see, this is the RAO30 view. The NCC lies quite far away from the RVOT. But in the LAO30 view, we see the right coronary cusp and the posterior RVOT are in close proximity to each other. So at times, the VPCs arising from these sites can have quite similar ECG appearance. So we need to be very careful while selecting the site of origin and deciding the route of access for our patients. Thank you, ma'am.
Thanks, Dr. Sukriti. I would have loved if you had, I'm not sure if I missed it, the last image that you show, which is LAO, which is RAO.
Ma'am, this is the RAO view. The
Yes.
spine can be seen here on the right side. And this is the posterior most is the non-coronary cusp.
Yes,
and this
in
is
the RAO.
Yes, ma'am. And
Yeah.
this is our...
Yeah, please speak on all these structures in relation to the LAO.
Yeah, ma'am. So this is the RAO30 view. We have a pigtail catheter placed in the root of aorta. Just anterior to our aorta lies the RVOT. Just the closest being the posterior RVOT, and ahead of it lies the anterior RVOT. This is our ablation catheter lying in the RVOT. The posterior most cusp in relation in the RAO30 view is the non-coronary cusp. And the anterior most is the right coronary cusp. As we can see, the non-coronary cusp is quite far away from our RVOT. But in the LAO view, this is a LAO30 view, the right coronary cusp lies in close proximity to the posterior RVOT. So this is the same thing which we already discussed in our initial slide. Just a fluoroscopic representation of the same.
Wonderful. I think this image helps the students very much because it takes some time to understand all these anatomy. I would want the moderators to come in now.
Thank you, ma'am.
I think both Dr. Deepti and Dr. Sukriti had a very wonderful presentations, especially for the DM students. They're always confused with the PVCs, with how the PVCs will affect the tachycardias, and also how to identify them on the ECGs, as well as a very nice case by Dr. Sukriti here depicting the angiogram correlation also. Wonderful cases. I must congratulate both of them.
Thanks, Dr. Arpita.
Yeah, I agree. I think both cases were great. For the first presentation, I think you did allude to the post-excitation, the hysterefractory PVCs that can sometimes cause not just pre-excitation of the next atrial beat, but also post-excitation. Just wanted you all to keep in mind that one of the differential diagnoses for a long RP tachycardia is something that we see commonly in the pediatric or the young population, which is PJRT. even though that's a misnomer. It's not a permanent junctional reciprocating tachycardia. It's an SVT that is mediated by a decremental conducting accessory pathway. And so when you put his-refractory PVCs in PJRT, you will get that post-excitation phenomenon instead of the pre-excitation. So that was one comment. And then in this case, again, beautifully demonstrated. I'm glad you demonstrated the anatomy so clearly. But just one point, you showed us the unipolar signal. I think if it was actually coming from the right coronary cusp, you would have seen a little bit of an R wave and not such a clear QS pattern. So it's very important to look at that unipolar signal. If you saw a little bit of an R wave, you might actually want to explore the right coronary cusp with your ablation catheter before deciding where you want to come on with RF energy. So I think the unipolar signal is very important as well.
Thanks, Dr. Molly. Dr. Aparna, ma'am, would you want to comment?
I think both of them were exceptional. And the only thing I wanted to make out and wanted Sukriti to highlight that when you are in the RVOT, one must exercise caution. RVOT is a thin walled structure. One must remember not to push your catheters. If you are in the RVOT, your catheter is stuck somewhere, please do not push it with force. It's a very thin walled structure. We burnt our fingers earlier, but I think wonderful presentation by both. Congratulations to both the speakers.
Thank you, ma'am.
Thank you, ma'am.
Thanks to you.
So with that, we'll move on to our third session for today, and that's the must know in pacemakers. Dr. Naini, are you there?
I am. I'll just try to share my screen.
Yes. Dr. Naini is going to speak on the nuances of clinically used sensors. It's a very important topic, and let's hear it from her.
I hope my slides are visible.
Yes, they are.
Okay. So, because we're talking about rate sensors primarily, although I will come to some other things, we need to understand what the problem was when we started pacing. So this is one of the very initial papers in NEJM. This was in the 1950s. This is actually the first report of intracardiac pacemaker. Everything before this used to be extracardiac. So this was a major breakthrough, of course, in the sense that patients who were having Stokes-Adam attacks and patients who had asystole after cardiac surgery suddenly had a much longer life expectancy than, ever before. But it didn't take very long to realize that although these patients improved a lot clinically, they continued to have a poor quality of life and a poor exercise capacity. And this eventually could be ascribed to two things. The first was a lack of atrioventricular synchrony with the initial devices, which is, of course, now corrected. And the second was an inadequate heart rate response during exercise, what is, of course, better known as chronotropic incompetence. So when we talk about this, we need to understand what happens with exercise. So, of course, as I'm sure everybody knows, when anybody exercises, their cardiac output increases. And it can increase many times. So if the resting output is around 5 liters per minute, it can increase to 20 to 30 in normal people and even higher in trained athletes. But this increase in cardiac output, of course, has to be mediated by an increase in stroke volume as well as in heart rate. So what happens in the paced patient? When we re-establish AV synchrony, at rest, we give them effectively a 20% more stroke volume. But the same does not apply when the patient exercises. The cardiac output, even with AV synchrony, does not increase more than 8 to 10% with exercise. So that means heart rate is actually the major determinant in the exercising patient. So the stroke volume rises to about 50%, but then it plateaus off. And as the patient would continue to exercise further, the heart rate response would be the main thing mediating the further increases in cardiac output. So if we cannot increase the heart rate with exercise, these patients will continue to experience poor quality of life and poor exercise tolerance. So this was now something that needed to be corrected, which led to the need for rate responsive sensors. But before we go on how rate response sensors work and how they function, we need to understand how we define chronotropic incompetence. Because up to this point, we were actually pacing patients who had low ventricular rates. But what about the patients who had low atrial rates or could not increase these atrial rates when they exercise? So, they were not very happy with their life. So I used to have this question quite frequently in my DM days. The most simple way to define chronotropic incompetence is to have them do an exercise test. And if they cannot attain, say, 75% at least, preferably 85% of their maximum age predicted heart rate, which would be 220 minus their age, then they are likely chronotropically incompetent. A more eloquent way of doing this is the chronotropic response index. This is a rather complex calculation that I would prefer not to go into. Simply put, a chronotropic response index is if you were to plot a graph between the heart rate reserve and the metabolic reserve, the slope of that graph would represent the chronotropic response index. And anybody who has a slope of less than 0.8, that basically means for their achieved METs, they are not able to achieve a good enough heart rate, could be labeled to be chronotropically incompetent. So again, before I go into rate response sensors, I would like to just go over the timing cycles of pacemakers, because we do need to discuss this in going forward. So dual chamber pacemakers have a lot of intervals, which should not scare anybody. So basically, there is a low rate, which is determined usually by the lowest ventricular or maybe the lowest atrial rate. So this is usually programmed to maybe 50 or 60 beats a minute. Once an atrial sensed or an atrial paced event, either of those is generated, there is an AV interval, which differs for sensed and paced AV events. Once this AV interval expires, there should be a ventricular event. If there is no intrinsic ventricular event, the pacemaker will choose to pace at this point. Following a sensed or a paced ventricular event, there is a post-ventricular atrial refractory period. This is to avoid oversensing of any atrial activity that may be detected here, because the atrial lead could at this point detect a far field T, for example. And the sum of the AVI and the PVARP is what we refer to as the total atrial refractory period, because the atria is refractory immediately after an atrial impulse or an atrial sensed impulse, and it continues to be refractory after a ventricular impulse as well. So this total atrial refractory period determines what we know as the upper rate limit, because the total duration the atria is refractory would be the maximum rate the pacemaker can establish. This is what we conventionally program to say a rate of around 130 in most devices. Now, when the patient does exercise, we would expect the AV interval to shorten, because that is what happens physiologically. We would also expect the PVARP to shorten, because since retrograde conduction also becomes faster with exercise, so the VA conduction becomes faster with exercise in normal people and in these patients, we don't now require a PVARP that is as long as it was previously programmed. So as AVI and PVARP both shorten, the upper rate limit should increase. So now the patient should be able to establish faster rates. So this is where sensors come in. So whenever we have rate-related sensors, they establish a sensor indicated rate. This would be the rate that the sensor suggests that the patient should have. So if the patient is running and needs a rate of 120, the sensor would now tell the pacemaker that it needs to have a rate of 120. And for V-pace devices, this is fairly simple. If you have a single chamber VVIR and the sensor says it needs to pace at 120, it just paces at 120, and that's the end of the story. It becomes a little trickier when you have a dual chamber device. So now there will be a sensor indicated rate and there will be a sensor upper rate limit. Why is this different? So basically, one of two things can happen. The patient can have a sinus response that is appropriate. So the patient starts running, he develops sinus tachycardia to a rate of 130. Now this upper rate limit comes into play, and with that sinus rate, with that sensed A, the device can continue to pace at a rate of 130, maintaining AV synchrony and maintaining the rate response as well. The other possibility is this patient was chronotropically incompetent, and when he starts running, he's unable to mount a fast enough sinus rate. In this case, the sensor indicated rate now tells the device that it needs to start pacing at a rate of 120, and it starts pacing at the rate of 120 with ventricular conduction as to the upper rate limit. So whether the device tracks or it paces the atrium and then tracks depends on which is higher, the sensor indicated rate or the patient's intrinsic rate. Okay, so now I'll come to something about sensors, which is what the topic was intended to be. So now we need something that would sense the patient's activity and respond appropriately. So we are looking ideally at something that is very sensitive, so that can detect not only physical stress, but also mental stress, not just somebody running fast, but somebody climbing up an incline. We would need something with high specificity. So something that does not pick up on, say, vibration when the patient is traveling or electromagnetic interference. We would need something that responds rapidly. And so there should be a good speed of response. It should attain a heart rate that is proportional to the patient's requirement. And it should be easy to program and easy to implant. So we don't want any specialized devices, and we want as little physician interference in the programming as possible. But as of today, this does not exist with a single modality. These are the two types of sensors or the loops that are currently available. So this is the open loop system is what is seen in most devices. So we have a sensor. This will sense physical or mental stress, and I'll just come to the types of sensors. The device has an intrinsic algorithm that the physician can program further. This will lead to a change in the rate. Now, whether the rate increases or decreases after this, there is no feedback to the device, and there's no change based on the rate. Some devices now have a closed loop system, and this in good news, there is minimal physician involvement in this. So you don't need to program these much. They'll just detect the change in rate. They will change the rate accordingly. And once the rate is changed, there'll be a feedback process that will lead to, decrease or increase of the rate as required by the patient. So like I said, we need a device with high sensitivity that should respond to physical stress and hopefully to mental stress as well. This is, of course, not very robust at the present time. This physical stress and exercise are what most of the devices respond to. So the most common ones are 1 and 2, which is body motion sensors, activity-based sensors, accelerometers, as they are otherwise known, or respond to an increase in minute ventilation. There are other ways, of course, like to use O2 utilization. They're not very common clinically as of now. So like I said, the two most common are activity-based and minute ventilation sensors. We do have closed loop sensors, like I discussed, which would provide a feedback back to the device. And now with the advent of leadless systems, all of these are also rate-responsive pacemakers. And these have either accelerometer-based or temperature-based sensors. These sensors are not very commonly in use, and a lot of them require specialized leads or specialized devices. So at the moment, they're not freely being used. So activity sensors are, for our purposes, very important to understand. These were the first rate adaptive sensors. And even in current devices, which have dual sensors, they're always one of two. So the good thing about activity sensors is they are incorporated in the device. There is no specialized device or lead that needs to be put. They respond very rapidly. So the onset of rate response is very rapid. The problem being that at higher rates, the heart rate response may not necessarily be proportional to the metabolic demand. And they can get affected by environmental noise. So in that sense, they're a little less specific. So this is the conventional activity sensor. This is what is being used today. So the conventional activity sensors, and a lot of the residents who would have done device implants with, older physicians, they do tell you to keep. So they, like my teachers used to tell me, to keep the name of the pacemaker towards the upper surface or towards the chest wall, so that the blank surface faces the pectoralis muscle, and there should be no lead underneath the pacemaker. There is one simple reason for this. The activity sensor is actually adhering to the backside of the pacemaker, and this detects vibration in the pectoralis muscle and sets up voltages which would accelerate the rate response. Fortunately for us, none of the current devices do have this. They now have an accelerometer that is freely mounted inside the device, so you can place it any which way. And then these are more sensitive as well. So this was actually picking up on the vibration of the pectoral muscle. This now picks up on acceleration that is perpendicular to the device. So say the patient starts running and the acceleration is perpendicular to the device, this device would detect that. The major advantage with this, if the pectoralis is not exercising with these devices, it just does not get picked up. So if the patient is bicycling, there is no upper body movement, it would not get picked up with this. It would get picked up with this. So this is, of course, the current technology. I will just skip this because, okay. So then what happens once an activity sensor picks up?
Dr. Nani?
Hello. Okay. So once an activity sensor picks up that there is an increase in activity, it would increase the rate. The degree to which it increases the rate can be programmed. Now, this graph is something that is a little important that I would just want to bring your attention to. This is how we program most devices. So there's an activity of daily living rate that is programmed. There's an upper rate limit, which is intended to be attained during exercise. This is the rate that is there during most times. So this is around 90 to 100. And there's a rate that can be programmed when the patient is exercising. And these are the programmable parameters. So we can program the degree of ADL activity of daily living response. We can program an exertion response. And we can also program how fast the device would respond and how fast it would decrease the rate. The other important sensor are minute ventilation sensors. And these are, again, quite simple, quite common. And definitely in most dual sensor devices, these are one of the sensors that are used. Importantly, if the patient voluntarily hyperventilates or has any abnormal respiratory pattern, the sensor starts firing. So it has a low specificity in that sense. And in certain specific situations, such as mechanical ventilation, electrocautery, and magnetic resonance imaging, these sensors do need to be disabled. Importantly, all Boston devices are currently using these sensors, so we should pay special attention to that in these situations. So minute ventilation obviously depends on the minute ventilation when the patient starts respiring. So as the exercise intensity increases, the minute ventilation increases up to a certain limit. This is mainly mediated by an increase in tidal volume. After this limit, once the patient has attained this limit, which is called in other words an anaerobic threshold, the minute ventilation increases out of proportion to the metabolic requirement. So if the minute ventilation sensors were to work up to this point, they would suddenly abruptly increase at this point. And then the proportionality stops being there. So basically, they detect transthoracic impedance, and that is, of course, very simple to imagine how they would detect that. They give a pulse that is detected by the lead tip. So the CAN gives a electrical pulse that is detected by the lead tip, and as we know, impedance is the the division of the voltage by the current. Okay. The last type of major sensor I want to discuss is the closed loop stimulation. And I do want to remind everybody that this has a very specific application. As of now, this is a Biotronic patented algorithm that has a very specific application in patients who are presenting with vasovagal syncope. And this is also not available on all their devices, but some of their devices. So the physiology behind closed loop sensors is that they would detect a drop in cardiac output early. They would change the rate response to match the response during vasovagal syncope. And they would have a feedback that would come back and reduce the rate once the vasovagal syncope has been aborted. Again, this is an impedance-based sensor. So, but the impedance is detected at the lead tip. So it actually detects an decrease or an increase in right ventricular contractility. So when the patient is about to have a vasovagal syncope, there is an abrupt increase in RV contractility, both because of reduced right ventricular filling and because there's a sympathetic response that increases RV contractility. So this increase in impedance prompts the device to start pacing much earlier than a conventional rate responsive device would. A conventional rate responsive device would actually not pace here at all. So briefly about dual sensor devices. So a lot of devices now, especially higher end devices such as CRTs, do employ more than one sensor. Usually this would be a combination of an activity based and a minute ventilation sensor. The benefit here is quite clear. So activity based sensors have good response times but are poorly proportional at higher heart rates. Minute ventilation sensors respond late but are have better proportionality at higher heart rates. So it sort of blends the two to create a graph that is more physiologically responsive. And there have been studies which have compared chronotropic competence in dual sensors versus single sensor devices, which have found dual sensors to behave better than single sensors do. Of course, leadless pacing systems are now all the rage. So, and they do have their own separate sensors. I would think it would suffice to say that the Micra group of devices by Medtronic have accelerometer-based sensors, which are basically the same as accelerometers in implantable devices, but they're deployed with the leadless pacing system. And the St. Jude as well as Abbott, so NanoStem and AVR, both have temperature-based sensors. Now, these are quite interesting in that, so they suggest that once the cooler blood from the periphery comes to the RV, there's a fall in temperature, which would stimulate these devices to start pacing faster. And then, of course, as the temperature increases, they continue to pace faster. So this was all about rate response, but there are certain other things sensors can do. This is from Boston Devices. So they came out with this Heart Logix algorithm. So they'd used a lot of these in heart failure monitoring, including heart sounds had been used. They had used transthoracic impedance as well as respiratory rate, heart rate, and patient activity levels. And individually, all of these had been shown to predict that the patient would go into heart failure. So they made a composite algorithm incorporating all of these criteria. And whenever the device would detect a change in these criteria, it tends to give an alert. And it was found that even irrespective of BNP, the heart logic status did indicate that the patient was about to go into worsening heart failure or need heart failure hospitalization. Again, from Boston Devices, they do have sleep apnea monitoring. This is also thoracic impedance based. So they always had a minute ventilation sensor that was always detecting thoracic impedance changes. They just now used it to sort of develop an algorithm that would detect sleep apnea episodes at night. And that does appear to correlate well with polysomnography as well. Thank you for the opportunity and everybody's time.
Thanks, Dr. Nani. That was quite an elaborate presentation for sensors. I want the moderators now, Dr. Sridevi ma'am, Dr. Kirtika, and Dr. Vanita ma'am, to please come in.
Nice presentation, Naini. You did a detailed presentation. So for the DNB students, basically, they should understand what the sensor are for, and if a pacemaker patient comes back to them, how they need to adjust the algorithms. So for a Medtronic, Abbott, and minute ventilation, the algorithms are quite different, and if the patient comes back with palpitation in a Medtronic device, what they need to do, how they need to talk about, also should be understood clearly. So activity adjusting the pacemaker device, they should understand. Nice presentation.
Dr. Kirtika? I don't think we have Dr. Kirtika. Dr. Ajay Nayak sir would want to make a comment.
Yeah, very nice presentation. Nani, you are pretty comprehensive. I just would like to make a point regarding in some patients, in case even after exercising, the heart rate is not going up too much, you can actually change the activity sensor threshold to more sensitive so that the heart rate can go up faster and remain faster for a longer time. Or if the patient feels too much palpitations with even minimal activity, you can increase the threshold, the way the accelerometer works, so that it becomes slightly less sensitive and the heart rate would not go up too much. So these are tweaks which can be done while programming. But very nice presentation. Very good.
Can I come in, Neeti?
Yeah, ma'am, sure.
So one thing I think, Naini, very good presentation. But I do want to make a mention here. Often we see that the patients, when implanted with the pacemaker, are sent home with the default settings. And in a sick sinus, you must make sure that you've actually programmed the sensor on Sometimes the patient goes back home on DDD and is being apaced. So that's a comment which I'd like to make, but so comprehensive, so well, and we as clinicians must make sure the sensors are on in sinus node disease patients.
Dr. Vanita, ma'am? Dr. Kirtika? So, okay, I'll also want to make a comment. So, just as Dr. Aparna madam said about the sinus node dysfunction, in fact, on the contrary, I would want to make a comment on the AV block patients, because there are times when we give DDDR or the rate responsive pacemakers to AV block patients as well, whereas their chronotropic competence is preserved. Maybe we can switch or keep it only to the DTD mode and then see if the patient is competent and the rates are keeping well. The rate responsiveness can be switched off. Dr. Deep, any comment from your side? Dr. Deep? I
To the final.
Okay. I don't think he's able to hear us. So with that, I thank Dr. Nanny for this wonderful presentation, and we'll move on to our last presentation. Dr. Priyanka will come in now. Dr. Priyanka, are you there?
Yes, ma'am, I'm there.
Yeah, wonderful. Dr. Priyanka is going to speak on the newer anti-arrhythmic drugs and their role in atrial arrhythmias. Please start your presentation.
Ma'am, are my slides visible?
You can make it to the presentation mode, please.
Yeah, yes, ma'am.
Wonderful. We can see you now.
Good morning, everyone. So I would like to thank the IHRS team for giving me this wonderful opportunity. So today we are going to have a discussion on the newer anti-arrhythmic drugs, abutolide, dofetilide, and barnacalant. One common thing between these three anti-arrhythmic drugs is all of them are class 3 anti-arrhythmic drugs, and all of them are used in some or the other way in the management of atrial fibrillation or flutter. So before trying to understand any antiarrhythmic drug, it is very important that we have a basic idea of a cardiac action potential. So I'll not go in much detail. You can read from the textbook. I'll go very fast over it since we have a lot to discuss. So cardiac action potential mainly has 4 phases. Phase 0 is the depolarization phase, which is mediated by the inward movement of the sodium ions. Phase 1 is the early repolarization phase, which is mediated by the outward movement of the potassium ions. Phase 2 is the plateau phase, which is mediated by the influx of the mainly of the calcium ions, and in the later phase maybe some sodium ions. Phase 3 is the repolarization phase, which is mediated by the net outward movement of the potassium ions, which is mediated mainly by the IKS and the IKR channel. Phase 4 is the resting phase. So class 3 antiarrhythmic drugs mainly act on the phase 3. By blocking potassium channel, it basically slows the repolarization phase, so which in turn increases the refractory period of the cardiac tissues. By increasing the refractory period of the cardiac tissues, it basically decreases the excitable gap. So here we can see that it is a reentrant tachycardia which is going on with a huge excitable gap. After adding class 3 drugs, this excitable gap is being reduced, and the leading edge of the tachycardia wavefront might not find any excitable cells, may end up meeting refractory tissues, and the tachycardia is very likely to get terminated. Second thing with this drugs is it increases the action potential duration. So this action QT interval is a surrogate marker of ventricular action potential duration. So any drug which increases the action potential duration is very likely to increase the QT interval. So now we'll discuss each of these antiarrhythmic drugs one by one. So first we'll discuss ibutolide. So ibutolide is a class 3 antiarrhythmic drug. It is available only for IV use, not available for oral use because of extensive first pass metabolism. It comes in the strength of 1 mg 10 ml solution. It is an FDA approved drug for pharmacological conversion of recent onset AF and flutter in patients without severe structural heart disease. So mechanism we have discussed previously. It blocks the IKR channels and augments the late sodium current also, prolongs action potential duration. It increases the refractoriness, not just the atrial, but also the ventricular tissues also, which causes reduction in the excitable gap and contributes to the termination of tachycardia by virtue of its action of increasing the action potential duration. It also has a tendency for QT prolongation. So because this drug carries a risk of QT prolongation, it's very likely to cause torsades. The risk of torsades is estimated to be 2 to 7%. The risk is higher in patients with reduced LV ejection fraction. Therefore, ibutilide is best avoided in patients with reduced LV ejection fraction. Conversion time, if you talk about the conversion time, more than 80% of the patients get terminated to sinus rhythm within 30 minutes of drug administration. Data regarding use of ibutilide in persistent atrial fibrillation and flutter are not impressive. So doses and administration. For patients with body weight less than 60 kg, 0.01 mg per kg is a standard dose administered over 10 minutes. For patients body weight more than 60 kg, 1 mg over 10 minutes. If the patient does not respond to the first dose of ibutilide, second dose can be administered after 10 to 15 minutes. If even after second dose of administration of ibutilide, patient does not respond, electrical cardioversion can be attempted. So here is a case scenario, a 34-year-old presenting to us in the hospital emergency room with a complaint of palpitations, echo done, which is showing structurally normal heart, normal ejection fraction, and patient is hemodynamically stable. So we gave ibutilide to the patient. After giving ibutilide, this is the ECG. So here we can see that although the rhythm is now sinus rhythm, but there is a QT prolongation, but triggered after depolarization, which is appearing as R1T PVCs. A few minutes later, the patient started having complaint of lightheadedness. So this was the monitor, which was showing ill-sustained run of torsades. So the moral of the story is, torsades is the most feared complication of ibutilide. So despite ibutilide being indicated for the pharmacological cardioversion in atrial fibrillation flutter patient, it is not very commonly used or in the cardiac centers all over India. We are reluctant to use ibutilide. So it is very important that we know how to give ibutilide. So before administering ibutilide, it is very important that we get the serum potassium and magnesium levels of the patient and treat any hypokalemia or any hypomagnesemia before initiating the infusion. Consider giving IV magnesium 2 grams prior to administering ibutilide, irrespective of the serum magnesium levels. Although the prophylactic use of prophylactic role of giving IV magnesium is still debatable, but a couple of studies have found that it enhances the ability of ibutilide to convert the atrial fibrillation or flutter to normal sinus rhythm, and it also helps to prevent QT interval prolongation and treating the torsades. So it is always beneficial to give prophylactic dose of IV magnesium. So the third point is, once we see that AF is terminated or any ill-sustained VT run, so it's coming, it is better to stop the infusion. Even after the infusion is completed, it is always important to keep the patient on cardiac monitor at least for 4 hours. We should not give ibutilide to patients who are having a baseline QT prolongation. QT interval is more than 500 milliseconds, or patients having severe LV dysfunction, since these patients are more prone for torsades. Patients who is already receiving class 1A or class 3 anti-arrhythmic drugs. So this we have already discussed. We should keep the patient at least minimum for 4 hours after discontinuing the ibutilide infusion, or until the QTC interval returns to normal. Most of the time, the QTC interval returns to baseline within 2 to 4 hours after stopping the infusion. In cases where arrhythmia persists, monitoring can be extended beyond 4 hours. Availability of baseline bedside defib machine is essential. So amiodarone is the most commonly used drug over most of the cardiac centers for pharmacological cardio version. So it is very important that we know that how ibutilide is different from amiodarone. So efficacy wise, not much difference, but the average conversion time, if we talk about, it's less with the ibutilide. 30 minutes for ibutilide, and for amiodarone, it is approximately 8 to 10 hours. Hemodynamic wise, if you talk, amiodarone is more likely to cause hypotension. So moving on to the next antiarrhythmic drug, we'll have a brief discussion on dofetilide. So dofetilide, till now it was not available in India. I think a couple of months before it has been launched in India. So it is again a class 3 antiarrhythmic drug. It is a selective inhibitor of IHRS channels and augments late sodium channels. It's available in the form of capsules in the strength of 125 mics, 250 mics, and 500 mics. Its oral bioavailability is good. IV forms are not available in most of the countries, including US and in India also. If we talk about the pharmacokinetics, it's very important to understand its pharmacokinetics, since 85% of the dofetilide is excreted by the kidneys. So the drug doses needs to be adjusted in accordance with the RFTs to prevent the drug toxicity. And again, the action potential duration is prolonged in a dose-dependent fashion, which causes QT prolongation. And this drug also carries the risk of torsades. So one of the property with dofetilide is it has a property of reverse use dependence. That means that its antiarrhythmic action declines as the heart rate increases. Theoretically speaking, it is an undesirable feature for drug used in pharmacological cardioversion of patients with AF, in which its effect at higher rates would be preferable. So because of this property, it is more effective at maintaining sinus rhythm than at converting atrial fibrillation, and this drug has a more tendency for QT prolongation at slower heart rates. So just to talk about reverse use dependence, like this is the first slide which we have discussed. So the class 3 antiarrhythmic drugs mainly affect on the phase 3 of cardiac action potential. So which is mainly mediated by the IKS and the IKR channels. So by IKR channel, if you talk about the IKS channel, this is the most important channel which mediates the influx of the efflux of the potassium ions at a higher heart rate. So by blocking the IKR channels, the IKS channel increases and it compensates for the slowing of the slowing of the repolarization phase. So several large randomized clinical trials have demonstrated the efficacy of dofetilide in conversion of atrial fibrillation to sinus rhythm, as well as in the maintenance of the sinus rhythm. For the conversion rates are approximately 30%, whereas if used for maintenance, the rates are 60 to 70% of cases at 1 year. So that means that it is more effective at maintaining sinus rhythm than at converting atrial fibrillation. If you talk about the conversion time, 70% of the pharmacological cardioversions occur in 24 hours, whereas 91% within 36 hours. So it is suggested that electrical cardioversion should be considered if the patient does not cardiovert within 36 hours of the start of the dofetilide therapy. It does not depress the myocardial function, so it can be safely used in patients with heart failure and ventricular dysfunction. Like ibutilide, it also carries the risk of torsades. The incidence reported is 0.9 to 3.3%. The incidence can be higher if the dofetilide dose is not properly adjusted for the kidney functions. So how we are supposed to initiate dofetilide safely in a hospital setting? So we should always know that we are not supposed to prescribe dofetilide in patients who are at high risk of torsades, like patients having baseline bradycardia or sinus node dysfunction or second or third degree AV block. Baseline QTC is more than 460 milliseconds, or serum potassium is less than 3.5. Calculated creatinine clearance is less than 20 ml per minute, or patient is on other concomitant QT prolonging drugs. Dofetilide should always be begin in the hospital under cardiac monitoring. Before starting dofetilide, we need to check the baseline QTC and calculate the creatinine clearance. Initiating dose of the dofetilide has to be administered as per the creatinine clearance. If the creatinine clearance is more than 60, the starting dose is 500 mics BD. If the creatinine clearance is between 40 to 60, the doses is 250 mics BD. If the creatinine clearance is between 20 to 40, the dose is 125 mics BD. Less than 20, dofetilide is not indicated. Moving on, like QTC should be measured after 2 to 3 hours of first dose, and the dose needs to be adjusted accordingly. If the QTC is increased by 15% or the absolute value is more than 550 milliseconds, we need to decrease the dose by 50%. So patients with AF who are increasing the dose of or reinitiating dofetilide therapy should be admitted for a minimum number of 3 days to a healthcare facility. Once the patient is discharged on a stable dose of dofetilide, we need to follow up the patients every 3 to 6 months with the QTC and RFTs. So moving on to the next antiarrhythmic drug, Varnacalant. So this is again a class 3 antiarrhythmic drug. The feature which distinguishes Varnacalant from ibutilide and dofetilide is it is an atrial selective drug. It selectively acts on the atrial tissues and not on the ventricular tissue. So it has a less tendency to cause torsades. Selectively is an inhibitor of IKUR channel. It is available in the IV formulations only. It is approved in Europe and Canada, but it's still not approved in US. It's still an investigational drug under FDA. So the most recent ACC IHRS guidelines for the management of atrial fibrillation do not address the role of Varnacalant, as the drug is not approved to be used in the USA, but the European guidelines have recommended it as a first-line drug. So here we can see that it's more, the drug is more effective in short duration AF and not in the long duration AF. So drug doses wise, the initial infusion dose is 3 mg per kg administered over 10 minutes. If the rhythm is still not converted, we can repeat a second dose, 2 mg per kg. And still if it is, the patient continues to be in fibrillation flutter, electrical cardioversion can be attempted. So it's a figure taken up from the JIBes. Here we can see that IKUR channel is selectively present in the atrium and not in the ventricle. So by inhibiting the IKUR channels, it increases the refractoriness of atrial tissues and not the ventricular tissues. So that is the reason it doesn't cause much QT prolongation, and the risk of torsades with this drug is very less. Same thing. If you talk about the adverse drug reactions, most commonly patients receiving Varnacalant complaints of sensory disturbances like altered taste sensations or tingling sensations or sneezing. Other cardiovascular effects like hypotension and bradycardia are common. And in very rare cases, QT prolongation and ventricular arrhythmias can be seen. So contraindications of Varnacalant, patient having hypotension or severe LV dysfunction or coronary artery disease or baseline QTC prolongation or severe valvular stenosis, they should not be given Varnacalant. So since Varnacalant and ibutilide both can be given for pharmacological conversion of atrial fibrillation flutter, it is very important to know that how Varnacalant differs from ibutilide. So Varnacalant, on one hand, it does not prolongs the QT interval. Efficacy wise, if we talk, both the drugs have similar efficacy. The average conversion time with ibutilide is almost 30 minutes, and with Varnacalant it's 10 minutes. QT prolongation with ibutilide is more common, and Varnacalant it is less likely to cause QT prolongation. Hospital stay, minimum of 4 hours cardiac monitoring is required for ibutilide, and maybe more if some torsades or some VT runs appear. But with Varnacalant, that is not the case. Patient can be discharged at 2 hours after completion of infusion. So Varnacalant versus amiodarone. with Varnacalant, the conversion rates are higher. Varnacalant versus oral flecainide and propafenone, the cardioversion rates with Varnacalant are higher, and the hospital stay is shorter with Varnacalant. So to conclude, we can say that so today we have discussed these three drugs: ibutylide, dofetilide, and Varnacalant. So ibutylide and Varnacalant are available in IV preparations, and these two drugs are mainly used for the pharmacological cardioversion of atrial fibrillation and flutter. Dofetilide is, on the other hand, is more effective as a maintenance therapy. If we talk about the conversion time, with ibutylide, the conversion time is 30 minutes. With Varnacalant, the conversion time is 10 minutes. Dofetilide can also be used for pharmacological cardioversion, although not effective. The conversion time with dofetilide is 24 to 36 hours. The risk of QT prolongation is more with ibutylide and dofetilide. Varnacalant carries a least risk of QT prolongation. So it requires less hospital monitoring, whereas ibutylide and dofetilide requires in-hospital monitoring. Both ibutylide and dofetilide are FDA approved. Varnacalant is yet an investigational drug under FDA. And both ibutylide and dofetilide are available in India. Thank you.
Thanks, Priyanka. That was a lovely presentation. I think you made all the three drugs, the role of all the three drugs very clear. At this point, I invite Dr. Sridevi Madam, Dr. Daljit, Dr. Shivani Rao, if she can make it, to please share some comments.
It's a good presentation. First thing we should understand is there is a huge usage of amiodarone in the country. When we have these newer drugs, like especially ibutylide and dofetilide, I think all the postgraduates should understand how to utilize ibutylide and dofetilide, which have lesser complications than amiodarone per se. That is one point I would like to make. And ibutylide has been noted to, like she's already mentioned, it terminates more atrial flutter. And potassium magnesium correction is very, very important, and to look at the QTC.
Dr. Daljit?
Yeah, hi. So I think she has covered everything. Only point I'd like to elaborate here is any patient here. Can you hear me? Am I audible?
You're audible, but you're not visible. We'd like to see you as well.
Okay, fine. So the thing is, any patient you're taking for cardioversion, either you use Varnacalant or you use amiodarone or you use ibutylide, avoid electrolyte imbalance. It's true not only for ibutylide but other two drugs also. So if there is an electrolyte imbalance, patient is in refractory class 4 having uncorrected septicemia or acidosis, we should not attempt cardioversion. The outcome will not be good. That's the only line I would like to see. Otherwise, I think it's been covered extensively by Dr. Priyanka. Thank you.
Dr. Shivani? The other moderators are welcome. Dr. Arpita, Dr. Aparna ma'am.
Maybe Neeti, I'll step in and comment a bit.
Right, sir. Right, please.
Take the opportunity since the others are not around. Just a couple of points. Actually, this was an excellent exam-oriented presentation by Priyanka for the DM-DNB candidates. That's excellent. See, practically speaking, what happens is with ibutylide, you need to observe the patient in the hospital for at least 24 hours. So if you are bringing in the patient for elective cardioversion, it becomes a slightly inconvenient drug to use, because otherwise we get in the patient cardiovert and send them electrically cardiovert and send them home in another 4 to 6 hours. But if you give ibutylide, then you need to observe them in the hospital for at least 24 hours. So I practically use it more in patients who are already in the ICU for some other reason. Maybe the patient has undergone CABG and then is getting AF. You've tried electrical cardioversion, then you don't want to give repeated shocks. So these patients, you can give ibuprofen. That is how I have been using it. The other thing is with dofetilide, it's a mandatory 72 hours hospitalization. So that becomes even more inconvenient because the patient is otherwise only taking oral drug and you need to keep him in the hospital for 72 hours. So you need to have a pretty good reason for giving this drug then. And again, I use it generally for patients who have already developed amiodarone induced thyroid dysfunction. So for some reason, you're not able to give amiodarone to these patients. You bring them in cardiovert and then I put the patient on dofetilide. And obviously, then you need to observe for 72 hours that you need to do. But it's a good drug to have a good option to amiodarone for patients with LV dysfunction where you are not otherwise able to use amio. So this becomes a good option. Vernaculant, obviously, we don't have at the moment. Thanks.
Thank you, sir. One comment I want to make is that when we admit these patients and we give ibuprofen and there is and dofetilide, so there is a risk of QT prolongation and torsades. So I think the family counseling is very important because we might observe a riskier arrhythmia while treating atrial fibrillation. So family counseling is at the outset is very important. And of course, electrical cardioversion might have to be done if the patient lands into torsades. But I think as a start, because these are relatively newer drugs, we are having newer experiences with these. This is a very good presentation, and it has given us a lot of confidence in initiating these drugs. And thanks, Dr. Ajay Nayak, sir, Dr. Sridevi, madam, for sharing their own perspective of these drugs. Any other moderator who would want to come in? And I've got a question also from a participant who says that RHT with atrial fibrillation, is there any room of these drugs? Dr. Nayak, sir, Dr. Sridevi, madam, any comments on this?
Enough information, but this is something where we can do it. In India, we have patients with rheumatic heart disease, atrial fibrillation. So there will not be any data from abroad for this. So if you are interested, this is the field to get into, and you can do a proper study and publish. This is the right way to do it.
Good. Dr. Parna, ma'am, any comments?
Yeah, that's exactly what I was going to say, that we don't have data, and we should remember that even the trials that have been done are on small population of patients with these drugs. So it's very hard. We don't have yet for rheumatic heart disease. While Dr. Nayak says, I think that's a splendid idea. It says that the regulatory bodies in India are so stringent that to carry on a drug trial in India is really an uphill task, but it's worthy of an attempt.
Dr. Sridevi, ma'am?
I think we should try, because the countries outside will not be able to give us any data. We can start with mild to moderate disease and then see if we can further it up. Because as the question is asked, there are no clear-cut answers to date.
So, Dr. Shivani, is she there? Okay. So Dr. Shivani is actually with us, but she's having some network problem. But with that, I would say it was a wonderful session, and it's good to finish it on time. Dr. Ajay Naik sir can have the last closing remarks.
Yeah, thank you, Dr. Neeti, Dr. Aparna, for conducting this. This was fantastic. Yesterday was International Women's Day. This was a good occasion. I thought women EPs have been there in the country for a long time. They've been in the forefront. But this would be a good way to showcase, and the entire meeting has been conducted flawlessly. Excellent presentations by everyone. Dr. Deepti, Amira, Kirtika, Sukriti, Naini, Priyanka, and thanks to Dr. Sharda Sridevi for being there. We brought them out from the background they were hiding for the last few years, but thanks for being there. And again, thanks to Dr. Molly for staying up late at night and coming into this program.
So,
Dr. Deep, over to you. You've done a great job. Thank you very much. And Dr. Yash, especially thanks because I requested him to postpone the Sion Hospital presentation to next month because we wanted to do this all ladies program coinciding with the International Women's Day.
So Dr. Molly has actually shared a message and she wants me to convey the message, and she states that all presenters did a great job. You all should be so proud to be training them. I wish them a very successful career. And she actually made it, it was past midnight for her and she did attend the session. It was great on her part. And with that, I think we can close the session. We are right on time, and it's good to have attended the session. Thank you so much. Lovely presentations.
Thank you.
There is a question. Let me just see if, how do these drugs compare with flecainide for flutter is one question, if somebody wants to answer. Final.
Yeah, I think there was one slide by Priyanka in the end. With ibutyllite, the conversion rate was highest, and with vernaculant. With flecainide and propafenone, it was around 70% and 60%. So since these are IV drugs, so probably a little more effective compared to flecainide and propafenone.
So great. Thank you. Thank you all.
Thank you.
Okay. Have a good day. Have a great Sunday.